and the Journal of Hepatology, the Journal of Hepatology being really the most comprehensive, you'll get what you need to know. And I will say at the outset that in training, I heard none of this. So this was really new to me. When I put this lecture together, I was dealing with a subject that I knew very little about, other than, oh, somebody's on a drug and they have a liver problem. Well, the two and two are connected. So let's start with some of the background, general concepts in epidemiology. And what we're most worried about, of course, is that drug-induced liver injury can lead to acute liver failure. And of course, we've talked about ALF on several lectures, and we know that the most common cause of ALF is idiopathic. But then we get through the viral, the direct toxins, magic mushrooms. We talked about Wilson disease. We haven't talked about pregnancy, but we will be talking about that when we deal with other problems, like fatty acid oxidation disorders, for example. And then, of course, we talked about vascular. But drugs are extremely important. And here are some of the drugs. And now, if I asked you or asked any of the fellows to tell me what the most common drug in the United States that leads to liver toxicity and acute liver failure, what would you say that would be? Take a guess.
I would guess that it's acetaminophen. Yeah, she said it.
Bryce?
I was going to guess acetaminophen, and I heard Mariam start to say paracetamol, and I think,
Okay. All right. So now we have to talk about the difference between adults and pediatrics. So if you looked at what the common causes of acute liver failure in selected countries, they're shown here, and it's absolutely right. It's paracetamol in the USA. 40% of known causes of ALF are due to paracetamol in the U.S. In other countries, they're the hepatotropic viruses, hepatitis E, hepatitis B, so only in the U.S. and the U.K. does acetaminophen take the top spot. So the incidence of DILI in the general population is not well known. You see the estimates here, but really the only cases that we know about are really those that come to medical attention requiring hospitalization. And of course, those are the ones that lead, obviously, to really significant clinical problems. But the estimates are shown here. And if we look at the most common causative drug classes in the USA, now we're talking about liver injury, not acute liver failure. This slide was acute liver failure. So that we've talked about, but now we're really talking about liver injury that does not necessarily lead to liver failure. And surprise, surprise, the most common causative drug class in the USA is not paracetamol, but is anti-infectives. And of course, the paracetamol is usually suicidal attempts. So anti-infectives take the lead, followed by herbal and dietary supplements, cardiovascular drugs, and then down the list is anti-neoplastics. Now, of the anti-infectives, here's another question for you. Which one is the most common in the USA to cause liver injury? Take a guess. Anyone? Take a guess. This is not, I'm not going to chop your head off if you're wrong.
Is it like Tetris?
Cephalosporin.
Excuse me? Miriam, I didn't catch that.
Cephalosporin. Yeah,
okay.
cephalosporins.
All right, Bryce, you have a guess?
I was going to guess tetracycline because I think like rifampin is worth, but I don't know how many people are really taking rifampin in the U.S. So.
All right, Let me tell you, it's a very common drug. One of the most common drugs prescribed, it is Augmentin.
Oh, wow.
So Augmentin is 91% of drug-induced liver injury. And I caution you to look over to the right column, and you'll see here that depending on the drug, the phenotypic expression of injury can be quite different. It can be cholestatic, it can be a mixed picture, it can be an acute hepatitis picture. Now, of course, we're always talking about isoniazid. Isoniazid certainly causes an acute hepatitic picture and very commonly causes injury, but it's, oh, ho hum, we take them off the dose or whatever it is. So some of these are can really be a problem, and some of them can be just a minor annoyance. But overall, Augmentin is the most common. In pediatrics, however, if we look at the antimicrobials in children, and this is where does children and adults separate? Probably around adolescence. Here, minocycline. But you see that the numbers are very, very small. And so, indeed, drug-induced liver injury caused by antimicrobials in children is relatively uncommon, rare, I would say. I caution you, we'll talk a little bit about valproate, because valproate in the appropriate clinical situation can be a bad actor in dealing with problems of DILI. But overall, the antimicrobials still take the lead, but the numbers are small. I caution you to, when you have a child who comes in and has elevations in their transaminases, that one must not assume that it's a prescription drug or a virus or something else. But I put this list up for your edification. These are all of the herbal and dietary supplements known to cause liver injury. And they can be as common as aloe vera. Everybody takes aloe vera for something. Senna, if you see over in the right column, senna, which I don't use it typically, but others do for constipation. Green tea, a whole range of compounds that you would normally think were pretty benign, still in the proper setting have the potential for causing liver injury. So,
Proper setting in this context mean like a significant overdose for most of these, or
well, I would think in terms of herbal and dietary supplements, we're really not talking much about overdose. But it's a good question, and this brings us to the reasons why someone develops drug-induced liver injury, and it reflects a very complex drug-host interaction. The drug, now, how does the drug cause injury? Does it cause direct injury? Is it a metabolite that causes injury? Is it idiosyncratic or hypersensitivity? Those are the kinds of questions we need to ask. So you have cellular injury initiation, and there are pharmacologic responses. There could be metabolites which are benign and eliminated, or metabolites which are toxic. We've seen that with acetaminophen. We can have direct toxicologic responses, binding of the drug to various receptors in the hepatocyte, leading to an oxidative stress, mitochondrial injury. Mitochondrial injury extremely important when we talk about drugs like valproate. And then obviously causing a cell death, which is identified either histopathologically or when we see in more sophisticated tests the appearance of a DAMP, which is a damaged associated molecular pattern. And then all of this goes on, and what's the host response to the injury? We can either have an immune reactive inflammatory response that leads to further injury, or we can repair. And so all of this is, while this cascade of events is sort of what we would expect, it depends on what are the drug properties and what are the host factors. Are there genetic determinants? And all of these things have to be taken into account when considering whether findings of abnormal liver function studies is a manifestation of drug-induced liver injury. So DILI can present with a very heterogeneous phenotype, as I showed you earlier. In most cases, liver biopsy may not be available. When it is available, it may or may not be diagnostic, and I'll show you some histopathologic slides in a bit. And then we need to qualify the liver injury, and that is made by liver biochemistry. Typically, when one has acute liver injury related to drug, we can see marked elevations in your ALT, ALK phos, and your bilirubin. And the pattern of liver injury is classified according to what's known as the R factor. The R factor equals the times of the upper limit of normal of the ALT, 2, 3, 4, 5 times the upper limit of normal, divided by the times upper limit of normal of ALK phosphatase. It's not the absolute ALT or ALP, it's the times upper limit of normal of each of them. And that gives you what's called the R factor. And if the R factor is greater than 5, that suggests that it's direct hepatocellular injury. It's a hepatitic process. If the R value is between 2 and 5, that's a mixed liver injury that is possibly hepatitic or cholestatic. And then if the R value is less than 2, it is cholestatic. Now, it's simple enough to do this calculation on any patient who comes in with unexplained transaminasemia, because then you are prepared, if it is DILI, to understand what the etiopathogenesis is and develop an appropriate approach to treatment. So here's the patient who comes in at the top with abnormal liver tests. And is it acute hepatitis? Is it chronic liver disease? So do you suspect DILI? Well, one of the characteristics of DILI is you may have an acute hypersensitivity reaction. So we also want to look for other organ involvement over to the left. And then if you are suspecting DILI, and of course, you should ask our residents when they get a patient, how many times do they get a detailed medication history from every patient, as you should. And that includes not only prescription drugs, but over-the-counter medications, herbal and dietary supplements. So we want to do a detailed investigation on everything that is not food-related that the patient puts into their body. And then we need to calculate the time to onset, because not all drugs that cause liver injury cause it immediately. It can be dose-related or occur after some time. You can log on to LiverTox. You can Google LiverTox, and that will give you some guidance as to how to identify liver injury caused by specific agents. Then we need to define the pattern of liver injury. And of course, this is where our R value comes into play. Is it greater than 5, between 2 and 5, or less than 2? And then we deal with an etiologic assessment. Obviously, in many cases, DILI will be a rule-out diagnosis, a diagnosis of exclusion. We have to rule out other potential causes. If we really want to characterize the phenotype of disease, then obviously a biopsy is going to be required. And so I'm not saying that this whole cascade of events is going to take place in every subject who comes in with evidence of acute liver injury, but it at least should be considered. And this sort of general protocol, this general algorithm is quite useful. So again, abnormal liver enzymes at the top, a thorough history and physical, a complete review of medications, herbal and dietary supplements, calculate the R value. And again, if you are convinced that this is likely to be a DILI, or DILI is part of the differential, let's say your R value over to the left is greater than 5. That's a hepatitic response. So we want to do the acute viral hepatitis serologies. Second line tests can also be considered, like ceruloplasmin or other things. But again, we're dealing with an acute hepatitis. If it's mixed, we probably are going to follow the same exact protocol. If it's less than 2, if the R is less than 2, that's clearly cholestatic, and that's where imaging studies actually become the primary modality. What drug that we give often in pediatrics causes a typical cholestatic picture? I happen to have published an article on it, so I know a little bit about it. It's an antibiotic. We give it for sepsis. This you need to know about.
Is this cephalosporins?
Excuse me, Bryce?
Is this cephalosporins, like ceftriaxone maybe?
Well, you're close. What's cephalodrug? Ceftriaxone. Ceftriaxone causes an acalculous cholecystitis picture. It mimics gallstone disease. All right, so that's a clear cholestatic picture. And so again, if you have somebody who comes with an R value less than 2 and they're on they've been on ceftriaxone, that becomes a likely diagnostic possibility. And then obviously, after you've done all of this, you put it all together and try to come up with a diagnosis. So what are the recommendations we can make? All of this is theoretical, it's good, but in specific cases, how do we proceed? Well, we need to, as we've shown in the previous slide, and we'll show again, we need to define and classify the liver injury. Genetic testing may be required. We need to identify if there are specific phenotypes. How do we treat them? How do we manage drug-induced acute liver failure? And how do we prevent DILI? All of these are important problems that we need to address. So again, we can divide DILI on the basis of the mechanism of injury. So any drug given at a high enough dose for a long enough period of time has the potential for causing injury someplace. So clearly dose-dependent injury is important. But then there's dose-independent, which may be idiosyncratic. This could either be immune-mediated or allergic, or idiosyncratic based on toxicity of the drug directly. So this is non-allergic. For example, acetaminophen is clearly generally a non-allergic liver injury. It's caused by the toxic metabolite resulting from depletion of glutathione. So there are some characteristics of direct, idiosyncratic, and indirect hepatotoxicity. They're shown here. The most common cause is direct hepatotoxicity. That is, you give a drug, the drug itself is toxic to the liver. The time is rapid, usually within days, and the phenotypes include acute hepatic necrosis and acute fatty liver, the whole gamut caused by acute liver injury. And the most commonly implicated agents, of course, again, high doses of acetaminophen, and a variety of other drugs. NSAIDs are part of this, and cancer chemotherapeutic agents are obviously directly hepatotoxic as well. And the cause is these drugs have intrinsic hepatotoxicity when given in high doses. Then we have the idiosyncratic drugs. These are commonly the antibiotics. and they cause an acute hepatocellular hepatitic picture they may have a cholestatic component to them. Certainly in pediatrics, this tends to be rare. And then we have indirect hepatotoxicity. That's sort of somewhere in the middle, where anti-neoplastic agents, again, these may result from a variety of causes. Glucocorticoids, anabolic steroids are another one. It's one I used to see commonly when I was early in my career, when pumping iron was big, when the Arnold Schwarzenegger syndrome, everybody on steroids, that used to cause this kind of indirect hepatotoxicity. And so this is something that the agent, not directly, but through intermediate steps, causes injury to the liver or the immune system. Again, we all know that the cytochrome P450 pathway is the most common pathway for metabolizing most drugs. Again, glutathione, we know that cytochrome 450 is in zone 3, pericentral vein area. And when glutathione is depleted, generally because of a very high dose of drug given over a very long period of time, one can produce a bioactive toxic compound. Of course, this is the classic acetaminophen or paracetamol pathway for cellular injury. So, as I mentioned earlier, we can either have allergic DILI or non-allergic DILI. With immune-mediated or allergic DILI, there's a recognition of a specific drug-associated antigen, which recruits helper T cells, may also recruit B cells, producing antibodies, and we have the adaptive immune system that's activated. And then there's the non-allergic DILI. This does not involve the immune system directly, but here we just have an accumulation of either high concentration of drug or reactive metabolites in the hepatocytes. And typically, these are mitochondrial poisons. They also stress the endoplasmic reticular system with the generation of reactive oxygen species. This is the classic for valproate, for example. So if you have a patient who you suspect with a drug-induced liver injury, should we re-challenge them, particularly if the patient is on a drug that is required or preferential for the treatment of their disorder? Well, recommendations, and this again is from the AASLD, deliberate re-challenge with a causative drug in clinical practice is not advocated unless the clinical scenario demands such an exposure. In pediatrics, the one drug, certainly in pediatric gastroenterology, that you would never re-challenge someone on, what class of drugs, if they develop DILI, would you never re-challenge them of in our patient population? This is a drug that I suspect Dr. Levine used a lot, maybe not anymore, but probably used a lot at one time. I'm giving you a hint.
Oh, an immunosuppressive drug.
Which one?
Mycophenolate?
No, thiopurines.
Oh,
Thiopurines cause, and it's a mixed picture. You can have patients who are on the drug for a while and all of a sudden come in with evidence of an acute hepatitic picture. The problem with thiopurine toxicity is once you get an idiosyncratic reaction to the thiopurine, you cannot re-challenge because it's going to come back. And this not only is true for liver injury, but this is commonly with the thiopurines. The biggest problem is not liver injury so much as it is pancreatic injury. So they come in with acute pancreatitis as well as with liver injury. You cannot re-challenge them. Other drugs, such as isoniazid, you may want to restart, perhaps at a lower dose. because they don't generally result in severe recurrence of hepatotoxicity. So again, it depends on the drug that you're using as to whether or not you want to rechallenge. In most cases, if you strongly suspect DILI, you are not going to rechallenge with that drug. What about autoimmune hepatitis? Well, a number of drugs have been associated with drug-induced AIH, which shares many of the features of idiopathic autoimmune hepatitis. In at least one study, or several, up to 10% of AIH patients were considered to be drug-related. So suspected drug-induced AIH should be evaluated in detail, including a causality assessment, serology, genetic tests, and liver biopsy whenever possible. So again, see what the scenario is. Obviously, if the patient's not on any drugs at the time, you're not going to say that their AIH is drug-related. In patients with suspected drug-induced AIH and treated with corticosteroids, withdrawal of therapy once the liver injury has resolved should be accompanied by close monitoring. Again, in patients with drug-induced AIH, when they're treated with corticosteroids, they will have a resolution of their transaminasemia, if you will. But then they need to be followed closely, because if their AIH is not drug-related, obviously the disease is going to come back. So there are specific phenotypes that cause acute fatty liver. In those cases, as you might suspect, these are drugs which cause injury by interfering with mitochondrial function. And the number one drug in this case is valproate, which interferes with mitochondrial function and is particularly a problem in certain individuals that already have mitochondrial hepatopathies. The most frequent example in pediatrics would be the patients with Alpers-Huttenlocher disease, which is the POLG mutation. I'm sure Dr. Levine can tell you that this was probably on one of the boards she's taken in the past. It will be, again, valproate toxicity is almost immediate in patients with Alpers-Huttenlocher who take this for seizure control. So valproate itself is a common hepatotoxin and can lead, obviously, to acute liver failure as well. Patients have an acute rise in liver enzymes, present with jaundice, and an index of suspicion is crucial in identifying the drug etiology.
You said this was called Alpers-Huttenlocher?
Alpers-Huttenlocher, right.
Thank you.
Or the mutation is POLG. P is in Peter, O-L-G is in George.
Yeah, I see it. Thank you.
Mitochondrial hepatopathies.
Which is a mitochondrial hepatopathy, which I will lecture to you when we present mitochondrial hepatopathies. There are drugs associated with fatty liver disease. Of the drugs that we would give, a methotrexate would be the most common. And it's an acute NAFLD is associated with the accumulation of fat in the liver. And again, methotrexate and the drugs we would use would be the most common ones associated with that. So, as I mentioned to you, the phenotype of these drug-induced liver injuries is quite varied. As shown here, panels A and B show acute hepatitis secondary to isoniazid. Again, looking at a portal area here, we don't know where it begins and where it ends. The arrow points to a bile duct here, which is not damaged. This is sort of a bland hepatitis. And again, normally you should see, if this is the portal area, you should see a marked demarcation between the portal area and the parenchyma. You don't see it. All right, this is crossing the limiting plate. Here in panel B, we see that, again, loss of normal sinusoidal architecture. And what's all this staining here? What am I pointing to?
Is that bile that's not
Yeah,
getting where it needs
right.
it? Yeah.
Right. This is intrahepatic cholestasis. Again, this is isoniazid, so it can be a mixed picture. This is minocycline. You see here a really a large lymphoid aggregate, which is really obliterating the portal area. All right. And this is also an interface hepatitis, which only shows scattered lobular inflammation. Again, minocycline related. So there's wide variability. This is these are the patients that I used to care for. This is anabolic steroid disease. It's really bland. There's expansion of the portal area, but minimal inflammation without interface hepatitis. Interface hepatitis would be a crossing of the limiting plate. And there's no evidence of, this is just an invaginated bile duct. That's why you see what apparently are these cells here, but there's no real injury of the bile duct. And here you have canalicular cholestasis. This again is a patient with bodybuilding or anabolic steroid injury. Here we have lobular inflammation showing a mixed hepatitis. And here again, we have more inflammatory cells. And here's the portal area with some spilling over the limiting plate. So again, these injuries can be quite varied, even not only from drug to drug, but within the same class of drugs. What you will see on the boards is acetaminophen injury with zone 3 necrosis around the central vein. You see here complete destruction of the hepatocellular architecture in the area in zone 3. This shows some sinusoidal dilatation. This is really a poor slide. Forget about this one. And this is methotrexate. Methotrexate is prominent for showing steatosis. So here's the obvious steatosis of methotrexate. This is amiodarone showing Mallory bodies. Mallory bodies being the collection of eosinophilic material in a dying cell. And you can see what the Mallory bodies look like. So again, what do you have to remember? Obviously, you have to remember what it looks like for acetaminophen. Of the biopsies that you may see on the boards, the ones for acetaminophen injury would certainly be the most likely one that you would encounter. So in pediatric DILI, interestingly enough, again, this is a consequence of the drugs that cause DILI. Jaundice is the most common symptom. So cholestasis, again, going back to our R value, we're generally in the 2 to 5 range or the less than 2 range for pediatric DILI. Biochemical values, and you notice here, the peak ALT is 727, peak AST 503, peak ALK Phos is 331. So these are typical findings. Again, when I see a patient coming in that I've never seen before, and they have a marked elevation in their transaminases, I'm always thinking DILI, because there are very few other causes of liver injury, hepatitis, etc., that cause that marked an elevation in your transaminases. And of course, when this is along with hyperbilirubinemia, then we really have a strong index of suspicion for drug-induced liver injury. The time course, again, depends on the drug. So A is amiodarone, B is diclofenac, which is a non-steroidal anti-inflammatory. C is, as Bryce mentioned earlier, a cepha drug. This is cefazolin, which causes a cholestatic. And D is let me just for a second here. Okay. D is anabolic steroid use. So let's skip amiodarone. We don't really see it. Let's look at diclofenac or a non-steroidal. So, typically when you place a patient on a non-steroidal anti-inflammatory drug, you typically want to tell them, well, if you're going to be on this drug chronically, you probably should have your transaminases checked in about a month. And this is why. Because for NSAID toxicity, if it's going to appear, it will appear after a month. Here's your ALT and your bilirubin. This is times upper limit of normal on the y-axis. Here, the alkaline phosphatase tends to be not much above normal, all right? So here we have the marked ALT and the bilirubin. This is chronic hepatitis due to cefazolin, all right? This is a single dose. And with a single dose, we have a marked increase in the bilirubin, again, up with the alk phos. ALT is not as dramatically elevated. And here's anabolic steroid use, mild elevation in ALT, prominent elevation in bilirubin. This is checked after 90 days. And here we have the drug that is monitored during the use of anabolic steroids. And as you can see, not much change. So again, depending on the drug, you want to monitor patients depending on how likely they are to develop DILI and when it's going to develop. So the stepwise approach, we have abnormal biochemistry with acute hepatitis. We suspect DILI. There are features that support a toxic etiology. Is there evidence of other organ injury? We want to have a careful inquiry for the exposure to herbal and dietary supplements, prescription and non-prescription drugs. Of course, if we have a lack of information, that's problematic. But in all cases when DILI might be suspected, you want to discontinue all non-essential drugs. And, there are hepatotoxicity resources. I showed you liver tox. It's sort of like poison control for the liver. And that will give you some guidance as to how to proceed. We want to calculate the biochemical pattern of liver injury, as I showed you earlier. Search for alternate causes. Obviously, we're looking at the hepatotropic viruses. In pediatrics, alcohol-related liver disease is not something we're concerned about. Obviously, we want to do autoantibody titers for AIH. Again, if the cholestatic picture predominates, we want to check for biliary obstruction through appropriate imaging studies. And consider the liver biopsy. Again, I would consider a liver biopsy in all cases where there is a safety margin, obviously, without a significant coagulopathy. Because again, in pediatrics, we're commonly trying to figure out whether this is drug-induced or whether this could be autoimmune hepatitis. Now, toxic liver damage is still considered to be an orphan hepatic disease with respect to therapy. There are very few approved therapies. The most important step is to discontinue the implicated agent. There are some drugs which may be used, cholestyramine in drugs that are lipid soluble requiring micellar solubilization, or those that undergo an enterohepatic circulation. Again, you have to know what the drug is before you would consider using something like cholestyramine. Again, in a patient with valproate, carnitine, because it enhances function of the mitochondria, it helps shuttle fatty acids across the inner mitochondrial membrane, may be used to decrease the course of valproate. What about N-acetylcysteine? Well, anybody with a drug-induced liver injury gets N-acetylcysteine. And the studies have not really substantiated its efficacy for drugs other than acetaminophen, but it's very safe. And certainly any drug that follows cytochrome P450 metabolism theoretically would benefit by a glutathione repleter, and that would be N-acetylcysteine. What about cholestatic injury? The use of URSO has never been shown to be efficacious. Keep in mind that DILI is the most common known cause of acute liver failure in the US and the UK. Remember that drug-induced ALF will often lead to liver transplantation. The exception, of course, is acetaminophen, which has a high rate of recovery if treated promptly. Again, as I mentioned on the previous slide, patients with idiosyncratic drug-induced ALF should receive N-acetylcysteine early in the course. Again, it's either going to help or be benign. And what about corticosteroids? These have not been shown to be substantiated, but again, if it's an AIH picture, you will probably use corticosteroids. Again, after that, you'd have to follow the patient closely to make sure that it's not the non-drug related AIH, which would require more prolonged corticosteroid therapy. I'll just put this up here for your edification. This is from King's College in London. The criteria for liver transplantation for drug-induced liver injury for acetaminophen versus non-acetaminophen. Again, these are patients who are really severely affected with marked elevations in their INR. And again, this is for you to look up on your own. I would only mention the fact that when you get an acetaminophen patient down on the left column at the bottom, if they are entering encephalopathy grade 3, they are likely going to require a liver transplant. So what's new? Not a lot, except for the fact that there are studies exploring specific circulating biomarkers for DILI. They're shown here. HMGB1 is a cytokine mediator of inflammation. Antibodies that neutralize it confer protection. And so this could be a biomarker for liver injury caused by DILI. There are also a variety of other biomarkers which suggest dysfunction of particular organelles. Glutamate dehydrogenase from mitochondria. Keratin 18 is a marker of cell death. MIR 122, which is a liver-specific miRNA, is something to identify the specific hepatocyte injury. And then we see hepatocellular necrosis, HMGB1, again, keratin 18, and of course, our friend ALT. So to conclude, DILI is an uncommon but clinically important form of liver disease. It's driven by how often the drugs are taken and the likelihood they may cause injury. There are multiple phenotypes of injury which vary according to agent or even within a specific agent. And this, of course, presents a diagnostic challenge. Recognizing the phenotypes of DILI is helpful in establishing the diagnosis, identifying the responsible agent, and providing insights into pathogenesis. And of course, a better understanding of DILI pathogenesis will allow for better diagnostics and ultimately improved approaches to prevention and treatment. The highlights for you: acetaminophen, valproate. These are the ones that are going to appear on the boards. They always do. But I thought this would be useful for you as an introduction to this very complex topic, because DILI is an important cause for morbidity in children and should be suspected, again, in the presence of acute marked elevation of your transaminases. And it requires a rigorous methodologic process of evaluation. The most common causes of DILI in children Up to adolescence are antibiotics and antiepileptics. From adolescence on, obviously, it's your acetaminophen. And the mainstay of DILI treatment continues to be the immediate withdrawal of the suspect drug. And my voice is about to go, so that's it.
Thank you.
Okay.
Thank you.
Also, how does my microphone sound now? I had it backwards earlier. I didn't realize it until I said ceftriaxone and nobody heard me. So can you